the Heart of Medicine, and it's May 29th. This video is the 14th video, I believe, ABIM preparation. So if you've seen the other videos or not, this is internal medicine pearls for any medical student, resident, physician, and of course, mainly for residents that are preparing for the internal medicine board examination. But of course, this is useful for all the rest. So this video is going to be quick. It's 8:30 p.m. I need to get other things done. I already reviewed these questions, but I'm just going to share with you the main pearls. Give me feedback, opinions. This is going to be one of the shortest videos. Tell me if you prefer these videos that are quicker or the more extended versions, which you can see on my channel. So let's see why I got questions correct, why I got them incorrect, and of course the ideas you learn from this while you do your own things. So this question right here, it's basically a 68-year-old male. He is a type 2 diabetic, and he was very well controlled. Now he's not controlled. So all of a sudden, you have type 2 diabetic, which was on medication, which has not changed his medications, and his diabetes is now worse controlled all of a sudden, and he's still taking his medications. So something's going on there, and add on to that he's lost weight and he's sort of fatigued. So what do we have to do? What's the next step? So yes, I wasn't exactly sure what's going on here, but I thought to myself the best answer here probably is a CT scan of the abdomen. There could be a cancer in the mix, and yes, a cancer. Which cancer would be causing this worsened diabetes control, weight loss, and vague symptoms? Okay, well, yeah, pancreatic cancer. So that's what we had to go check for, and that's why CT scan of the abdomen was the next best step. Another option, the second most voted one, was testing for islet autoantibodies. That's called the LADA, latent autoimmune diabetes of, I think, adult onset. So that's also known as diabetes 1.5. And that was not the answer, because that usually happens in people between the ages of 30 and 50. This patient is 68. They're more probable to be cancer and also a smoker and all those things going on. Okay, that's basically it. So if you have a patient with a typical diabetes mellitus that doesn't fit into any of the usual descriptions, accompanied by some concerning symptoms, as I mentioned, and smoker with cancer risk factors, do the CT scan of the abdomen, and that's about it. Okay. Let's go on to the next question. We're going quick. This next question is a 74-year-old male who has COPD. And basically, you don't have to read all this vignette. You just have to read the question. Which of the following do inhaled corticosteroids increase? And there you have the options. So basically, you didn't have to read any of that. You just had to focus on this. You maybe just had to go figure out, okay, the corticosteroids are for what indication? So you just barely can skim through it. You can see COPD. Okay, the steroids are inhaled corticosteroids. Well, there are not many indications for inhaled corticosteroids, so not even reading the clinical vignette, you can probably assume it's going to be for COPD. I cannot recall right now out the top of my head any other indication for inhaled corticosteroids. Let me know if you know of any other. So basically, you just had to go through the list, and I was basically here on the fence between cardiovascular mortality, yes, no. Well, there's a trial that showed that no, there's insignificant elevation in cardiovascular mortality, so the answer is no to cardiovascular mortality. So the answer was yes to pneumonia incidence, and just a couple things, risks associated with the inhaled corticosteroids. Of course, well, the risks will be dysphonia, skin bruising, oral candidiasis, and slightly increased risk of pneumonia. So you can definitely avoid the oral candidiasis. Just washing your mouth, not necessarily washing your mouth, just drinking some water and spitting it out. Not drinking, because it would maybe take some residues to your esophagus. So after you do the inhaled corticosteroids, just swish and spit out, right? And that will reduce your oral candidiasis risk significantly. Skin bruising and dysphonia, probably, I'm not sure how to fix that. Probably also swishing and spitting out sort of will clean that out of your oropharynx. You don't want that in your mouth. You want that to go down into the lungs. So after that job has been done, just rinse and spit out. That's the word I was looking for. And of course, slight increased risk for pneumonia. And of course, inhaled corticosteroids benefits outweigh the risks when clearly indicated, such as improving symptoms, lung function, and quality of life. And it also reduces the frequency of exacerbations. But this is in a specific subgroup of COPD patients. This isn't the ones that have an FEV1 above 60. These are the ones that have an FEV1 less than 60%. So we saw the table the other day, and less than 60 was like class 2, GINA class, I think it was class 2. Correct me if I'm wrong. So class 1, I think, was, let's see, 80, 50. I think there was above 80. 80 to 50 would be class 2, 50 to 30 would be class 3, and less than 30 would be class 4. So yeah, of course, the lower the FEV1, the worse off you are. So when FEV1 is less than 60%, that is when you want to consider the inhaled corticosteroids. If not, just make sure the patient is on a long-acting bronchodilator, and so let's go to the next one. This other patient is a 77-year-old male. He was basically having some interesting findings, such as weight loss. So this patient lost a significant amount of weight. It takes a long time finishing his own meals, and let's see, weight loss, poor appetite, takes long to finish meals. And a very important point right here is, let's look it up. has halitosis, decaying molars bilaterally, and dry mucosa. This tells you a story, right? This should make something ring a bell in there that probably there's a GERD, and he also had pneumonia in his right lower lung, and also coughing bouts right after eating. So he was coughing a lot right after eating or during meals as well. And he also had a history of a CVA recently. So all those things should point you in one direction, which is that this patient probably isn't swallowing adequately. The CVA probably generated this disorder in swallowing, and you want to check that out. The way you check that out is order a modified barium swallow. So the other potential option I had here was a GI endoscopy. The GI endoscopy, no, that will show you anatomy, but what you want to see is actually the motility, the function, and not so much the anatomy. So that's the main learning point. So what the patient had was oropharyngeal dysphagia, commonly seen after neurological injuries such as stroke, and is best diagnosed with modified barium swallow. Prompt diagnosis is essential to prevent aspiration pneumonia, which carries high morbidity and mortality. Now the next question. This question is an interesting one. I want you to focus on the main thing. So they're telling you this patient is having claudication. The calves and thighs, when she walks, become numb. But there are some important points. So it says symptoms worsen when she walks downhill, and the pain and numbness quickly subside with rest. That's something that is very important. Another important thing is that symptoms often occur at the grocery store but are relieved when she leans over a cart. So that should tell you right there what the diagnosis is. So the diagnosis for this is actually pseudoclaudication. So you have claudication, which is actually the arterial insufficiency or peripheral artery disease, and you have pseudoclaudication, which is very similar, but it's not a vascular problem. It's a neurologic or a nerve problem, right? And that's what the patient had. And how do you check for that nerve problem? Yeah, you don't do ankle brachial index, because that would be for claudication. For pseudoclaudication, you do MRI of the lumbar spine. So what's the main point here? That this pseudoclaudication is caused by lumbar spinal stenosis, which produces lower extremity symptoms exacerbated by walking downhill and relieved with rest and bending forward. These symptoms are known as, we already mentioned, pseudoclaudication, and we already know which test to search for. This other question now is a patient that you're trying to screen for alcohol use disorder. So the patient says he drinks socially. Remember that saying someone drinks socially means absolutely nothing. Almost everyone in the world will say, oh, do you drink socially? And almost everyone answers yes to that. And that doesn't tell you if they're drinking, if they're dependent on the alcohol, if they're drinking till they are inebriated or drunk, if they're drinking 5 drinks or less. So the most important thing, basically the question is, which of the following is the best next step in assessing this patient for unhealthy alcohol use? So it's one question. Start off with one simple question. That's the answer. Administer the single item screening test or alcohol use disorders identification test. So what's the question? If the patient is a male, how many times in the past year have you drank more or equal to 5 alcoholic beverages? And if the patient is a female, same thing, but 4 beverages instead of 5, I believe. So that's about it. Let's see. Uses the lower threshold of 5. And yeah, I think it's for a male, 4. Let's see. Often do you have 6 or more drinks? No, that's audit C. The single item is 5 drinks for a male and 4 for a female. After that, as you can see here on this table, if that is positive, okay, now go on to choose one of your other questions. And the audit C is a quick one. Probably the audit C is enough. The audit is 10 items, so those are the main ones. Let's see what we have here. Main points: a single item screening that asks patients, we already talked about that, is an effective tool to identify unhealthy alcohol use prior to asking further questions. The audit C is another widely validated instrument for assessment of alcohol use. What about the CAGE questionnaire? Because we also have the option of CAGE questionnaire. Option A, what does it say? The 4-item CAGE screening questionnaire is no longer recommended as an initial screen because it emphasizes complications of heavy use and fails to identify the full spectrum of unhealthy use. So that's about it. And other than that, we're going on to the next question. Okay, next question is basically a female patient who is a smoker who wants to stop smoking and mentions verbatim, I thought I could control it on my own, but the cravings, the key word there is cravings, are so intense. So a good medication that stops the cravings for alcohol is naltrexone. But of course, you have to just check on the clinical vignette that there's no contraindication for naltrexone. What are the contraindications? Liver disease is one. There's a couple, right? It's liver disease, kidney. Not sure about that. Oh, liver disease for sure. And that the patient is not on any other opiate medication because, of course, naltrexone is an opioid antagonist. So you'll throw them into sort of some withdrawal symptoms. And maybe there's something else. So let's see what else we have. So let's see, naltrexone can be initiated while the patient is still drinking. It has been shown to decrease alcohol cravings, reduce heavy drinking days. Heavy drinking days is defined as more than 5 drinks for men and 4 for women, which we saw in the prior question. And it also increases days of abstinence. Okay, so depot naltrexone can be used when there are concerns regarding non-adherence, and it is contraindicated in those taking opiates, acute hepatitis or liver failure. In these patients, use acamprosate instead. Okay, acamprosate will be better tolerated in that subgroup with contraindications. And that's about it. Some other things it might say here. No, that's it. Let's go on to the next one. This other question right over here is, this is an interesting, I got incorrect. So this is a 52-year-old man. And basically what the story is telling you is that the patient has rheumatoid arthritis, and the patient is on a DMARD called methotrexate, but the patient now it has been having symptoms, so we want to ramp up the treatment for the rheumatoid arthritis. And the question is, which of the following is the best next step in management of the patient? So I just crossed out some things, and I even crossed out the correct answer because I saw this option that says arrange for skin tuberculin testing. I'm like, this doesn't make sense at all. This patient does not have TB, is not exposed to TB right now. What's going on? This doesn't even make sense. Well, I didn't think about what medication we would use, because on top of methotrexate, you probably would do a biologic DMARD, which would be a TNF tyrosine, a tumor necrosis factor inhibitor. And with that, remember, you always have to check for the tuberculin testing. You want to make sure these patients do not have TB and are not at risk for it, because it would worsen TB. So if the TB is enclosed and you give a TNF inhibitor, TNF alpha inhibitor, the TB can become disseminated. You don't want that. You want to know that before starting treatment. You also have to check before starting a tumor necrosis factor inhibitor. You want to check the hepatitis. You want to check for hepatitis B and C. Okay, and that's the main point there. So I had no idea what to answer exactly, so that's why I just marked this one. I wasn't sure. It says that rheumatoid arthritis may be associated with P-ANCA, but it doesn't mean anything. Like, you can have P-ANCA elevated with rheumatoid arthritis that is not flaring up versus flaring. So it's inspecific. It won't help you much. So here you can see a nice little table. If you have the RA rheumatoid arthritis, you do methotrexate. If symptoms are persistent over 6 months, you step it up with the biologic TNF. And if there's an adequate response, you switch to an alternate TNF inhibitor, and of course continue methotrexate. If you can also do parallel therapy, which is adding another agent to the methotrexate, such as sulfasalazine and hydroxychloroquine, right? So now let's go on to the next question over here. This patient right here, 65-year-old Asian woman, just started acutely having red eye. Also painful eye, sluggish eye response, pupillary response to light, moderately dilated pupil. So there is no pain with eye movement. Her vision is markedly reduced, and she can count fingers at 2 feet. What is the most likely cause of symptoms? Yes, that is going to be acute angle closure glaucoma. That's basically it. So not much to mention there. Those are the findings of acute angle closure glaucoma, which are pain, visual loss, vomit, and headache. Abnormal pupil reactivity in an older individual is diagnostic for this. And this is an eye emergency. Patient should be referred immediately to the ophthalmologist, because you want to prevent irreversible damage to the optic nerve and, of course, blindness. This is a nice table telling you about eye disorders. I won't stay here much, but I just wanted to show you the angle closure glaucoma. Here you have it. Fixed. Yeah, we already talked about this. Okay, let's go on to the next question. This is an interesting question. 29-year-old woman with worsening fatigue for the past months, noticing dizziness, nausea, constipation, hair loss, and they're giving you several findings here, telling you she's also on an oral contraceptive. This is a rather sort of complicated question. She is hypotensive. Her blood pressure is 90/60, and thyroid gland is normal in size and palpation. Skin is dry, and she has sparse axillary and pubic hair. So there are several things going on. She also has some anemia. Anemia, and what else is going on? And her TSH is low. Her T4 is normal, but her free T4 is low. So the question is, which of the following is the most appropriate next step in management? And I was able to reduce these options just to 2, because I was able to determine that this is central hypothyroidism. So TSH is low, and free T4 is low, and if you have that, you would expect a elevated TSH as a feedback trying to ramp up T4 production, but that wasn't happening, so it's central hypothyroidism. But then I didn't know what to do with these 2 options. Well, it wasn't to check the FSH level, because this patient was on an oral contraceptive that can falsely reduce your FSH and not let you interpret it adequately. So that's not the answer. The answer was concentropin stimulation test. And the reason is that you want to figure out that this patient does not have concomitant glucocorticoid deficiency, because the pearl here is that you never start a patient that you suspect of having central hypothyroidism, okay, up here, on levothyroxine without first making sure that the patient does not have glucocorticoid deficiency. Because if the patient is lacking glucocorticoids and you give levothyroxine, what happens is that you can worsen, or you can predispose the patient falling into an adrenal crisis, because given the levothyroxine will increase metabolic demands, will increase the need for cortisol and glucocorticoids, and be a problem. So that's why you do the concentropin stimulation test, just to make sure you don't have that. And I basically told you the main points for this patient, and that's about it for that one. What did this patient have? What was going on actually? Well, this patient had a vaginal delivery 1 year ago, and what we suspect this patient has, based on the findings and all that, and based on the answer, is Sheehan syndrome. So you have different causes for low TSH and a low T4. Usually it's going to be central hypothyroidism, but some things such as subclinical thyroid toxicosis will give you actually these labs, but actually look like hyperthyroidism. Okay, and that is just because you're having the thyroid toxicosis sort of picture, and this patient might be taking T3 thyroid supplements, or be having an toxic multinodular goiter, for example. Another one is euthyroid 6 syndrome. So these are the patients that have been in the ICU with critical illness that are having this. You just treat the critical illness. You don't give them levothyroxine. And also some medications can alter the TRH or TSH feedback loop. So those are other options. And that's about it. So let's go on to the next question. We're getting close to the end. So this other patient is an 18-year-old female. She mentions that when she lays flat, she has problems such as blurry vision and the whooshing sound occurring with headaches. So that's a very interesting point right there. What that is trying to tell you is this patient has a specific type of headache, and that headache is idiopathic intracranial hypertension. So which of the following should be closely examined during the neurologic evaluation? Of course, it's a fundoscopy or optic fondi to check that this patient does not have indirect manifestations of intracranial hypertension such as papillary edema. So that's basically what they're trying to tell you here. And of course, a lumbar puncture with an elevated cerebrospinal fluid opening pressure is going to be also part of the diagnosis, over 250 millimeter of water. And now let's go on to or 25 centimeter of water. Now we're going to go to this other question. This is a 69-year-old man, and this patient is on intravenous antibiotics. And this patient basically, well, as you can see, it's time to get the kitchen going. So in summary, this patient was found to have bacteremia due to gram-positive rods in several bottles and also having diarrhea. And the question is, which of these are the mechanisms through which this patient got infected? So the answer was consumption of infected food, and they were trying to point towards listeria. I wasn't actually thinking of listeria, but the case in this patient is that this patient had several immunosuppressive therapy medications. So this patient had rheumatoid arthritis and rheumatoid arthritis on infliximab and hydroxychloroquine, and that's basically it. So I'm just laughing because one dog was trying to get here below me, and that's just difficult to continue doing these things with everyone on top of me. So let's see what we have here. Let's try to, I'm not sure what happened here. Let's try to see what's up here. Let's exit this screen. I'm not sure why this is acting out now. Yeah, there it is. So this patient, immunosuppressed, having the rheumatoid arthritis, of course. What's the findings? High fevers, chills, headache, nausea, diarrhea. So systemic symptoms with leukocytosis, with thrombocytopenia. So this was listeria. So when you see gram-positive rods in blood cultures, that's what this patient had. What are your usual suspects? They will be Corynebacterium species, Clostridium species, Nocardia species, or Listeria. So I just marked exposure to antibiotics because it just came to mind the Clostridium difficile, right? But this patient did not have risk factors, so that wasn't the answer. It was Listeria. Remember, in immunocompetent patients, you'll just have some self-limited symptoms, less than 48 hours, febrile gastroenteritis. But if you're immunosuppressed, it can be invasive disease, which can include, of course, bacteremia, sepsis, pneumonia, and meningitis. Ampicillin is the first-line treatment for invasive infection. And now let's go on to the next question. This other patient, 36-year-old female, has mild right eye pain worsened by eye movement, was found to have, on the MRI, several scattered ovoid-shaped periventricular white matter lesions. So they're basically telling you what's going on here, or waiting for you to make the diagnosis so you can tell them what to do next. I chose intravenous methylprednisolone because this patient had optic neuritis, which is a complication of multiple sclerosis, and that's basically the answer. Not much more to add there. And let's go on to the next one. This next one, this one I probably wouldn't have gotten until I learned after getting it incorrect, which is in a patient, basically in summary, patient with celiac disease, which of the following gives you the highest negative predictive value of the patient not having basically celiac disease. So this patient, both within normal. Okay, so not necessarily, no. So this is a patient that we're thinking maybe this patient has celiac disease, maybe not. A tissue transglutaminase antibody was performed. They are in normal range. Duodenal biopsies during upper endoscopy showed normal mucosa. And you have genetic testing of HLA subtypes are negative. So this patient is following a strict gluten diet. Which of the following findings is most useful to rule out celiac disease? Okay, so they give you the different options. And as you can see, tissue transglutaminase antibody was not the answer. It was the HLA, human leukocyte antigen testing results. So the interesting point here is that mostly all patients with celiac disease are expected to have an alteration on the HLA DQ8 or DQ2. So it has a low specificity. So if you have it altered, it doesn't mean you have it. But if you have it normal, it gives you a 99% negative predictive value. So it means that the HLA alteration is highly sensitive and, of course, not very specific. So that's basically it. So HLA typing is also unaffected by the diet. So even if the patient improved their diet, stopped taking gluten, your HLA DQ2 and DQ8 should remain unchanged. Meanwhile, the duodenal biopsy and the tissue transglutaminase antibodies can normalize in a patient that has done the right thing. So that's why if you improve your diet and all that and hadn't attained the tissue transglutaminase or the biopsies, probably best bet is going to be the genetic testing. And now we're on to the last question. This last question is a 34-year-old female with vaginal bleeding. This question was showing that she had an elevated beta HCG up to 7,100, was anemic because she's having vaginal bleeding. She also has some cul-de-sac fluid there. It says small amount of free fluid in the posterior cul-de-sac. and last menstrual period was 7 weeks ago. They're basically asking us what's going on, and pelvic examination shows a closed cervix with active bleeding from the cervical os, and the ultrasound shows a thickened endometrial stripe, a 4 centimeter complex right at nexal mass. Okay, so what's the diagnosis? It's not a abruptio placenta, or a rupture, basically, or that the placenta is just loosening up, right? Because this happens in the 3rd trimester. It's not complete hydatidiform mole because it's not telling you any findings for this. I think like the snowstorm findings and those sort of things. It's not it's not incomplete abortion because there's no open cervical os. The cervical os is closed. It's not pelvic endometriosis because it's not giving you the usual findings for that, and there's usually pretty bad pain associated to that. It's ectopic pregnancy, so that's the answer. So ruptured ectopic pregnancy typically have 1st trimester vaginal bleeding, lower abdominal pain, hemodynamic instability, and a complex nexal mass. Ruptured ectopic pregnancy is managed with surgery, and this is the usual flow chart of how you manage it. So as you can see here, every ectopic pregnancy usually ends up in a fetal, or the baby is not gonna survive, because that's why you need the uterus to be able to provide all this tissue that will support the baby and all that, because if you have an ectopic pregnancy that it might be growing in a fallopian tube, it's eventually gonna rupture because there's not enough supporting tissue there to hold it up. So if the patient is stable, ectopic pregnancy, if it's stable, you go on to the next step. You see the beta HCG if it's less than 5,000, or if there's no fetal cardiac activity. If the answer is yes, fetal cardiac activity and beta HCG over 5,000, meaning that it is still growing, then you go to methotrexate to induce basically the abortion. And if the patient is unstable, you just go to surgery. If there is no fetal cardiac activity, you go to surgery. If the patient is not a methotrexate candidate, you go to surgery. That's it for this video. See you in the next one, and